Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programs, Diploma in Critical Care Nursing, DCCN, BNS, 03 to Nursing Management in Critical Care Conditions, Block-1 Care of Critically Ill Patients with Problems of Gastrointestinal System, Unit 1 Acute Gastrointestinal Bleeding, 1.0 Objectives. After completing this unit, you will be able to enumerate the various causes of acute gastrointestinal (GI) bleeding, identify signs and symptoms in a patient with acute GI bleeding, state your role in different diagnostic tests to identify the source of bleeding, manage a patient with GI bleeding, and advise a patient to prevent the recurrent attacks of GI bleeding. 1.1 Introduction. Acute gastrointestinal (GI) bleeding is a potentially life-threatening abdominal emergency that remains a common cause of hospitalization. The source can be upper or lower, overt or occult. The patient can be either hemodynamically stable or unstable on presentation. Bleeding from the upper 0-1 tract is approximately 4 times as common as bleeding from the lower GI tract and is a major cause of morbidity and mortality. Recognizing the signs and symptoms of upper versus lower gastrointestinal bleeding is crucial for prompt and appropriate treatment, as it may point to many significant diseases and conditions. In this unit you will learn about concepts, definitions, causes, pathophysiological basis of diseases, signs and symptoms, assessment and management focused on acute gastrointestinal bleeding. 11.2 Definition and classification. In this section we shall focus on definition and classification of acute gastrointestinal 1 bleeding. 1.2.1 Definition. Gastrointestinal bleeding refers to any bleeding that starts in the gastrointestinal tract, which extends from the mouth to the large bowel. The degree of bleeding can range from nearly undetectable to acute, massive, and life-threatening. 1.2.2 Classification. Gastrointestinal bleeding can be roughly classified into two clinical syndromes: upper gastrointestinal bleeding and lower gastrointestinal bleeding. Upper gastrointestinal bleeding. Upper gastrointestinal bleeding is defined as the bleeding proximal to the ligament of Triads, Fig. 1.1 This type of bleeding may be the result of a variety of pathological processes and characterized by hematemesis, vomiting up blood, and melena, tarry stool containing altered blood. Fig. 1.1 Gastrointestinal bleeding, G.1. Tract above and below ligament of Treats. Lower gastrointestinal bleeding, usually the bleeding per rectum, especially in the absence of hematemesis, is the indication of lower gastrointestinal bleeding. Tarry stool containing altered blood may be due to the bleeding originating from anywhere between the stomach and the proximal colon. 1.3 Etiological factors. Gastrointestinal bleeding occurs due to number of etiological factors as given below. 1.3.1 Causes for upper GI bleeding, UGM. The causes of upper GI bleeding are as follows: A. Peptic ulcer disease, B. Mucosal erosive diseases, C. Esophageal varices, D. Mollae waste tear, E. Stress-related erosive syndrome, stress ulceration, F. Vascular anomalies. Let us explain each one of them. A. Peptic ulcer disease. You may recall that peptic ulcers are localized erosions of the wall of the digestive tract. Ulcers usually occur in the stomach or duodenum. Breakdown of the walls results in damage to blood vessels, causing bleeding. When the mucous membranes break down, they are unable to counteract the harsh effects of stomach acid. Nonsteroidal anti-inflammatory drugs, NSAIDs, aspirin, alcohol, and cigarette smoking promote gastric ulcer formation. Helicobacter pylori are a type of bacteria that also promote formation of ulcers. About 50% of UGI bleeds are due to peptic ulcers. B. Mucosal erosive diseases. Esophagitis is reported to be a cause of acute UGI bleeding. Inflammation of the stomach wall can result in bleeding in response to an inability of the gastric lining to protect itself from the acid it produces. Erosive gastritis is the second leading cause of UGI hemorrhage. NSAIDs, steroids, alcohol, burn, and trauma infrequently cause acute, massive UGI bleeding. Hematemesis is the most common presentation in acute UGI bleeding. C. Esophageal varices. This is the third leading cause of UGIB and has the highest mortality rate, between 40% and 70%. Swellings in veins of esophagus or stomach usually result in patients with portal hypertension and from liver diseases. Varices most commonly result from alcoholic liver cirrhosis. When varices bleed, the bleeding can be massive and catastrophic and occur without warning signals. Almost 90% of variceal bleeding presents with hematemesis, with or without melena. D. Mollay's tear. Mollay's tears occur within 2 centimeters of the gastroesophageal junction and usually associated with a hiatus hernia. It is believed to be caused by increase in pressure across the wall of the esophageal or stomach, usually at the esophagogastric junction, often as a result of vomiting or retching, and can also occur after seizures, forceful coughing or laughing, lifting, straining, or childbirth. Physicians often find tears in people who have recently binged on alcohol. E. Stress-related erosive syndrome, stress ulceration, stress-related erosive syndrome, SRES, is usually found among critically ill patients. The mucosal ischemia and gastric acidity play important role in SRES, resulting in bleeding. There is to be superficial mucosal lesions, mostly in the acid product NG portion of the stomach. O. Vascular anomalies, abnormal times, vascular structures are also the cause of bleeding among patients with chronic renal failure. Arteriovenous malformations most commonly present with massive acute hemorrhage. 1.3.2 Causes of lower gastrointestinal bleeding, LGM. The causes of lower GI bleeding are as follows: A. Diverticulosis. B. Angiodysplasia. C. Ischemic colitis. D. Polyps. E. Hemorrhoids and fissures. A. Diverticulosis. Colonic diverticula are one of the most common causes of LGI bleeding. Small out pockets or diverticula form on part of the wall of colon, large intestine, usually in a weakened area of the bowel wall. A person may develop several pockets, more common in those who have constipation and strain at stool. These are most common in the sigmoid colon and to a lesser extent in the proximal colon. The bleeding is usually painless and not accompanied by diverticulitis. Diverticulitis of large bowel results from protrusions of mucosa through muscular layers, generally at the site of nutrient vessel. B. Angiodysplasia. Angiodysplasia is one of the vascular anomalies. A. Malformation in the blood vessels in the wall of the GI tract. About 25% of LGI bleeding occurs in patients over 50 years of age with vascular anomalies. The lesions are usually multiple and most common in the large intestine and often bleed. The elderly and people with chronic kidney failure develop the disease most often. Bleeding usually occurs as bright red blood per rectum or as maroon-colored stool. C. Ischemic colitis. Mostly patients develop LGI bleeding while in intensive care unit. Ischemia of colon usually affects older patients. Ischemic colitis involves the left colon, the splenic flexor, and sigmoid colon, the areas between superior and inferior mesenteric arteries. The patient complains of sudden onset of abdominal pain and bleeding. D. polyps. Intestinal polyps are non-cancerous tumors of the GI tract, occurring mostly in people older than 40 years. A small proportion of these polyps may transform into cancer. Colonic polyps may bleed rapidly, or they may bleed slowly and go undetected. Hemorrhoids and fissures. Hemorrhoids are swellings of veins in and around rectum. Straining on passing of stool can cause them to bleed. Bleeding from hemorrhoids is usually mild, intermittent, and bright red. Massive bleeding is rare. Anal fissures, or tears in the anal wall, also may trigger small amounts of bright red bleeding from the anus. Forceful straining during passage of hard stool usually causes such tears, which can be very painful. 1.4 Pathophysiology. Any etiological factors when leads to bleeding. The blood in GI tract irritate 2. The stomach causing nausea and vomiting that is in the form of hematemesis, but when remains in the stomach for a long period. Give coffee ground appearance as partially digested. The accumulation of blood in the tract stimulates peristalsis, leads to increase in bowel sounds and diarrhea. Stool may be black and tarry melina or frankly bloody. GI bleeding with great loss of blood can rapidly decrease the blood volume, brings the changes in the hemodynamic status, tachycardia, hypotension, pallor, and decrease urine output. Unless the blood volume is restored, patient can go into hypovolemic shock that can lead to acidosis, renal failure, bowel infarction, acute coronary syndrome, coma, and death, as shown in flow chart Fig. 1.2 Flow chart of pathophysiology of acute gastrointestinal hemorrhage. 1. 5 clinical manifestations. Patients with GI hemorrhage present with times hematemesis, coffee ground vomiting, melena or hematochezia. The presentation of bleeding depends on the amount and location of hemorrhage, times complications of anemia, including chest pain, syncope, fatigue and shortness of breath. Times hemodynamic instability, i.e., low blood pressure, increased pulse rate, altered level of consciousness, decreased urine output, signs of aspiration, times decreased peripheral circulation, pallor, cold clammy skin, times anxiety. 1.6 Diagnostic assessment. Acute upper GI bleeding is diagnosed by the presence of melena, hematemesis, or blood in a patient's gastric contents on lavage. In comparison, bright red blood in the stool is usually, though not always, indicative of a lower GI tract bleed. The patients with acute GI bleeding must undergo times endoscopic examinations that include esophagoscopy, gastroscopy, colonoscopy, sigmoidoscopy depending on the presenting symptoms to rule out the site of bleeding. In case of angiodysplasia, mesenteric angiography may be required to visualize the lesions times in order to confirm the diagnosis. Biopsy, cytology, pH monitoring, manometry test may also be required in case of mucosal erosion, times blood samples for CBC, electrolytes, BTCT, cross-matching. 1.7 Therapeutic management. Caring for patients with acute GI bleeding can be challenging, but your nursing interventions on both the physical and emotional levels can make a difference. 1.7.1 Goals of management. The aims of therapeutic management must focus on following: times stemming the bleeding, times restoring hemodynamic status, times prevent further gastrointestinal bleeding, times identify and treat cause of the bleeding, times experience minimal or no symptoms of pain or anxiety. 1.7.2 Management. Times stemming the bleeding, times administration of 4 fluids such as normal saline or a balanced electrolyte solution, times administration of whole blood to restore the blood volume and components, times administration of packed red cells if required to restore oxygen carrying capacity of blood, times upper endoscopy whenever possible to seal the bleeding vessel, times gastric lavage. 1.7.3 Endoscopy. For most types of GI bleeding, endoscopic therapy is the treatment of choice and is often successful. Fig. 1.3 The most common form of endoscopic treatment is given below. 1. Sclerotherapy. Sclerotherapy involves injecting the bleeding vessel with a necrotizing agent. This traumatizes the endothelial layer of the GI mucosa, causing necrosis and eventual sclerosis of the bleeding vessel. 2. Heater probe. Laser therapy. Electrocoagulation. In this, a bleeding site and surrounding tissue is cauterized or heat-treated with a heater probe or electrocoagulation. 3. Rubber band ligation and hemoclips. During band ligation, bands are placed around the varices to create an obstruction to stop the bleeding. Fig. 1.3 Endoscopy. If the above therapies fail, then following procedure may be followed. Tamponade therapy. Treatment of variceal upper GI bleeding may also include tamponade therapy, typically with the placement of a Sengstaken Blakemore tube. Portosystemic shunt. Tubular intrahepatic shunt tips a channel between the systemic and portal venous systems is created to redirect portal blood, thereby reducing portal hypertension and decompressing the varices to control bleeding. Balloon tamponade. Balloon tamponade tubes stop hemorrhage by applying direct pressure against bleeding vessel while decompressing the stomach. 1.7.4 Drug therapy. Acid suppression. In an upper bleeding, proton pump inhibitors reduce gastric acid production and enhance healing of bleeding lesions. Correction of coagulopathy. If coagulation parameters, example, prothrombin time, are deranged, vitamin K or fresh frozen plasma may need to be administered. Reduction of portal pressure. If the bleeding is thought to be due to esophageal varices, a complication of cirrhosis of the liver, vasopressin analogues and rarelyl octreotide may be administered. Rarely, a Sengstaken Blakemore tube may be inserted to mechanically compress varices. 1.7.5 Surgical intervention. 1. In severe bleeding, in some cases laparotomy may be required to identify the bleeding source, prepare patient for the surgery, physical, psychological and legal, and give postoperative nursing care. Times when bleeding stops and the patient is hemodynamically stable, start nutritional therapy. The patient is observed for symptoms of nausea and vomiting and a recurrence of bleeding. 1. Feedings initially consist of clear fluids or milk and are given hourly until tolerance is determined. 2. Gradual introduction of bland foods follows if the patient exhibits no signs of discomfort. 1.8 Nursing management. Nursing management of gastrointestinal bleeding is discussed in following subsections. 1.8.1 Assessment. I. Rapid assessment. You need to do rapid assessment of bleeding, which is very crucial, irrespective of cause of acute GI bleeding. A rapid clinical assessment is essential, and a should focus on the immediate crisis. Patients with massive gastrointestinal bleeding remains a common reason for intensive care unit admission or in emergency department with hypovolemic shock. Along with shock, you will find hematemesis, bright red-brown coffee ground emesis, hematochezia, bright red stools, melena, black tarry stools. Patients with low-volume bleeding have no change in vital signs when they stand. They may appear anxious but have no other signs or symptoms. So, in a patient with GI bleeding, you should immediately assess for times airway, breathing and circulation, times blood pressure, times rate and character of pulse, times peripheral perfusion with capillary refill, times observation for the presence or absence of neck vein distension, times mental status, level of consciousness, times skin color and temperature, times the presence or absence of bowel sounds should be assessed, times urine output and specific gravity, times increased thirst, times complete history of events leading to bleeding episode, times place the acutely ill patient on cardiac monitor, Obtain oxygen saturation level. An indwelling catheter may be inserted to evaluate urine output Fig. 1.3 Clinical classification of hemorrhage. 2. Help the patient for undergoing various laboratory studies to assess the level of various parameters, blood for times CBC times blood urea nitrogen, BUN times serum electrolytes times blood glucose times prothrombin time times liver enzymes times arterial blood gases, ABGs, times type and cross-match for possible blood transfusions. Other laboratory studies, times vomitus and stools should be tested for the presence of gross and occult blood. Urinalysis provides information on presence of blood in the urine, and the specific gravity gives an immediate indication of patient's hydration status. Lee, assist for any endoscopic procedure. Tamponade therapy if necessary. 1.8.2 Nursing diagnoses, fluid volume deficit related to acute loss of blood. Ineffective peripheral tissue perfusion related to loss of circulatory volume, risk for aspiration related to active bleeding and altered level of consciousness. 4. Altered renal and cerebral tissue perfusion related to decreased blood volume. 5. Anxiety related to GI bleeding, the uncertain outcome. 6. Ineffective coping related to situational crisis. 7. Potential complication, hypovolemic shock related to loss of blood. 1.8.3 Implementation. Your goal as a critical care nurse is to restore and maintain an effective cardiac output and tissue perfusion and controlling the hemorrhage and further bleeding. To achieve these aims, you may follow the following protocol. Follow resuscitation protocol for upper gastrointestinal UGI bleeding. Times in severe bleeding, obtain adequate intravenous access, give rapid fluid resuscitation with lactate Ringer's solution, blood, whole blood, packed RBCs, and fresh frozen plasma may be administered to replace lost blood due to hemorrhage. Times protect the airway by intubating if required to avoid respiratory compromise from aspiration of blood, especially in patients with altered mental status. Times monitor vital signs every 15 to 30 minutes. Times give gastric lavage in case of upper GI bleed. Times check signs and symptoms of shock, and accordingly treatment should be started as soon as possible. Times keep the head of the bed elevated. Times oxygen inhalation may help to increase blood oxygen saturation, it not intubated. Times insert indwelling urinary catheter. Times urine output should be measured hourly. At least 0.5 milliliters per kilogram per hour indicates adequate renal perfusion. Times urine specific gravity should be measured. Times intake and output record should indicate an equal or positive balance. Times assist in obtaining central venous access when necessary to monitor central venous pressure cardiac output. Times once the patient has been stabilized, early endoscopy will likely be performed, although the history and physical examination are used to differentiate between upper and lower GI bleeding. Endoscopic examination is required to determine the exact site of the bleeding. Times vasopressive ARD stomatostatin may be used to anesthetize bleeding. Nursing alert. Whatever type of endoscopic procedure your patient undergoes, watch for signs of treatment complications, including fever, mediastinitis, pain caused by esophageal spasm, motility disturbances of the esophageal sphincter, resulting in esophageal reflux and heartburn, and perforation, as indicated by abdominal distension, a board-like abdomen, and decreased bowel sounds. Be alert for systemic complications as well. Cardiovascular complications include heart failure, heart block, and pericarditis. Respiratory complications include atelectasis, aspiration pneumonia, pneumothorax, pulmonary embolism, and acute respiratory distress syndrome. 1.8.4 Follow-up advice. Patient who has had one major bleeding episode is likely to have another following an acute GI hemorrhage. Continuous care focusing on the underlying cause of disease if possible and preventing the future episode of bleeding. The patient must be instructed to times avoid irritating foods, times prevent or decrease stress-inducing situations, times take only prescribed medications. Patient who requires regular administration of ulcerogenic drugs such as aspirin, corticosteroids, or NSAIDs should receive instructions regarding the potential adverse effects these agents may have on the GI mucosa. Taking the medications with meals or snacks lessens the potential irritating effects. Times smoking and alcohol should be stopped because they are sources of irritation. Times need for long-term follow-up care may be necessary. 1.9 Summary: gastrointestinal bleeding is a relatively frequent problem in the critically ill patients. Common causes of UGI bleeding include acute stress ulceration, ASU, peptic ulceration, and esophageal varices. Non-variceal upper gastrointestinal bleeding requires resuscitation and correction of coagulation disturbances before endoscopy is performed. If a bleeding ulcer is detected, it is often managed by an adrenaline injection or electrocautery into the base of the lesion and a proton pump inhibitor. Surgery is considered for all patients in whom bleeding persists. Despite endoscopic or medical therapy, for lower gastrointestinal bleeding or if there is no obvious upper gastrointestinal lesion during endoscopy, then selective mesenteric angiography with embolization of the bleeding point or colonoscopy with electrocautery or adrenaline injection for diverticular hemorrhage may be considered as an alternative to surgery. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.